Hello, everyone. Thank you for joining us for today's webinar. My name is Dana Burnett, and I'll be moderating today's event for everybody. I'd like to mention a few quick items before we begin. First of all, please make note of the features available to you within your GoToWebinar internet browser. In the lower right corner of your screen, you should see the chat box where you can enter your questions to Dr. Rouzier. They will be answered at the end of the presentation as time allows. This conference is brought to you by WorldLink Medical. We provide evidence-based CME accredited education in preventive medicine and age management with a focus in bioidentical hormones. The WorldLink Medical courses part 1 through 4 will start this coming January. It's practical, evidence-based, and Monday morning ready to start seeing patients. Don't wait too long to sign up. We have recently added to our membership program. Our new program starts in January 2018 and will now include the monthly webinars, monthly journal club, and access to the online research library through EBSCOhost. Don't miss out on staying up to date on the latest in BHRT and other topics related to preventive and lifestyle medicine. Watch for an upcoming email on how to join. Today's event is sponsored by an educational grant from MedQuest Pharmacy. We are grateful for their continued support in recognizing the importance of patient and prescriber education in the field of bioidentical hormone replacement therapy. They are true leaders in the industry, and we are proud to be supported by them. Dr. Neil Rouzier, for those of you that are new and joining us for this webinar, is a pioneer and recognized leader in the bioidentical hormone replacement field, treating more than 3,000 patients almost since its inception in the early 1990s. With over 17 years of experience as an educator and practicing physician and 29 years of emergency medicine experience, he has dedicated his life's work to uncovering the medical literature that supports safe and effective protocols for personalized patient care. He lectures worldwide on the benefits of HRT. He is also the author of Natural Hormone Replacement for Men and Women, How to Achieve Healthy Aging. It's my privilege to welcome Dr. Rouzier for today's webinar from his hometown of Palm Springs. Hello, Neil.
Hi, Dana. Thank you. When was that picture taken, anyway? Or is that my baby brother? Well, good morning, everyone, from sunny and warm Palm Springs. It's supposed to be a high of 85 degrees today and clear. Beautiful fall-like weather. The impetus for today's lecture was several-fold. Dr. Herman Pang from Phoenix sent me an article on the adverse effects of estrogen and the fact that estrogen is associated with a significant increased risk and incidence of breast cancer. I'm going to review this article and explain in greater detail what everyone has already seen and experienced through the courses, but still people don't get. In addition to that, there is a television journalist that recently called me and said that she has some questions and concerns about the hormones that I prescribed for her because every doctor that she has spoken with, and everyone is an expert in their field, they all completely disagree with me. They caution her, they tell her that she should not be taking hormones. She should not be on anything because of the harm and the risk of the hormones. And in addition to that, there's risk of breast cancer. In addition to that, there's significant other risk, and the risks far outweigh any of the benefits. My advice to her is please invite those people that are such experts and don't understand HRT to one of the courses. And the best way I can explain it to her was to explain it to the doctors that what you're thinking and understanding is true, but not for what we do. And then that's where the communication breaks down, where people will say, well, no, they're all the same. ACOG and NAMS, everyone says that they're all the same, and everyone fears estrogen. I'm going to review a couple articles from Dr. Rebecca Glasser. She is a breast surgeon oncologist from Dayton, Ohio, that has written and published many articles in Maturitas or Maturitas. on the benefits of testosterone and in women with breast cancer, as well as in women that have not had breast cancer but uses it as a protective modality. On the other hand, she too is deathly afraid of estrogen and can quote many different studies on the harms of estrogen in breast cancer, which is why she's a strong proponent of utilizing an aromatase inhibitor, similar to this article that I'm going to discuss this morning. It's interesting that Becky, at the beginning of her lectures, starts off her lectures with, everyone must understand that observation does not prove causation. And then she goes into these studies where what they observed were high levels of estrogen were associated with an increased risk of breast cancer. And it's so very funny that she'll start off with, observation doesn't prove causation, you have to see what happens when you give it. And yet she'll go immediately into, look at all these studies to show that high levels of estrogen are harmful in women. And even though she states it, she doesn't get it. And it's very fascinating that so many people state it and they don't get it. So Dr. Peng sent me this article, which is a good example of what people don't get, unfortunately. So the purpose is, several reports have demonstrated the association between high serum estrogen levels and breast cancer risk in postmenopausal women. There are probably 100 studies out there that show the same identical thing. There's not one study that shows the opposite. Every single solitary study in both men and women show that high levels of estrogen are associated with increased risk of breast cancer, dementia, diabetes, heart disease, heart attacks, and death. And when you look at this, you go, my God, why would anyone possibly want to use estrogen? That's purely an association. All association studies do not prove causation. What happens when you give it is what we want to know. You have to then look at interventional randomized controlled trials to see what happens when we give it and whether it causes harm or not. What study showed that giving estrogen to women increases the risk or incidence of breast cancer? I'm waiting. Everyone walking down the street, you can ask any woman, does estrogen cause breast cancer? Oh, yes. Ask any of this journalist doctors, does estrogen cause cancer? Oh, yes. Ask Dr. Glasser, does estrogen cause cancer? Oh, yes, absolutely. High levels are associated with. And they just don't get it. Conclusions from this article were postmenopausal women with high serum estrone levels, they looked at estrone, which can convert back upstream into estradiol. And most of the studies look at estradiol, not estrone, but this study looked at estrone. High levels of estrone significantly increase the risk for ER-positive breast cancer. The conclusion from this, which was very interesting, measurement of serum estrone levels would be clinically useful in the selection of postmenopausal women who can benefit from, here's where the dragon rears its ugly head, from prophylaxis with tamoxifen, because tamoxifen can prevent ER-positive breast cancer. Aha! There's your bias. For those of you that attended Part 5, Beyond Hormones, I spent 3 hours looking at academic, economic, pharmaceutical, and political bias. So the purpose of this article really is to promote tamoxifen, and recent articles have said we really don't hit it hard enough. We really need to look at using tamoxifen as a preventive therapy to prevent breast cancer in women. But no one looks at the other side of the coin. In that excellent article I presented in parts 3 and 4 from the medical journal Menopause, which was aromatase inhibitors, a time for reflection, looked at what happens when we use aromatase inhibitors and we block the estrogen receptor site, which increases the risk of heart attacks, strokes, dementia, Alzheimer's, osteoporosis and fractures, death, urogenital atrophy, sepsis, etc., etc. And all the harm when we block the estrogen receptor site that no one really focuses on. All we would want to focus on is you got to block the estrogen receptor site to protect the cancer. But on the other hand, everyone ignores the WHI, the EPIC-E3N trial from France, all of the subsequent studies with estradiol, where not one study with estrogen alone, when we gave it, increased the risk of breast cancer. The relative risk in most of these studies is 0.8 to 0.9. There's no increased risk. Every study shows a decreased risk, but yet everyone wants to block it because high levels are associated with. A high level does not mean anything because the visceral fat produces the high level of estrone. The visceral fat produces the high level of estradiol. And in all these studies, you'll see the higher the visceral fat, the greater the risk of the cancers. It's the visceral fat producing the estrone that's driving the cancer. Yeah, but it's the estrogen. How do you know that? Well, because it's elevated. Well, so are all the inflammatory cytokines, cholesterol, and visceral fat markers also elevated. Why do you think it wasn't that? Well, because it was elevated. Well, then how do you prove that it's not? You give it. In what study in the last 30 years when we gave estrogen alone was there an increased risk of cancer? Not one single one. But yet everyone falls back on, yes, but high levels are associated with. Even Becky can't get it. It's really disappointing when the experts in the field don't get what they don't get, which is true. Every study shows high levels are associated with, but every study when we give it shows that there's protection against it. Completely different. So you can't look at all these studies and say are associated with, and then come back and say it's harmful, don't give it. No, some studies are associated with, that's true, but the other ones are associated with are actually false, particularly when it comes to hormones. And people need to understand that, and they don't quite understand it. So this study here, which recommends tamoxifen in everyone, of course now the recommendations from the drug company is don't use it for 5 years in breast cancer survivors, extend it to 10 years, and they won't get breast cancer. Well, if they're still alive in 10 years, because they'll block their estrogen receptor site and die from a multitude of other things that we're causing that we don't quite realize or understand. So this is one of those great articles that nobody understands, and they'll read it and think and come away with thinking that and saying, estrogen is harmful, you got to block the receptor site, you got to get rid of the estrogen. All right, well maybe we need to start pulling the ovaries out of people, yanking them out at age 30. You don't need those ovaries anymore. But when we do that, every study shows that you die sooner. So people don't quite grasp it, and I hope this is a good example of association does not prove causation. So let's then jump into what I was giving my journalist a look at, well then what else can we do? Everyone fears breast cancer. It's not the estrogen. Yeah, but high levels are associated. I know. But no study shows harm when we give it. But what else can we give if we're really worried about that increase in breast cancer in those women that have high levels of estrone but can't tolerate tamoxifen? The majority of women that take tamoxifen stop it because they can't tolerate or stand the side effects. The other problem with tamoxifen is, yes, it increases the risk of blood clots, and more importantly, it stimulates the uterine lining just like estrogen does, and it requires progesterone opposition, which no oncologist understands or even considers because they know that progesterone causes cancer. Which then leads us to this next article. This is a great article that was published by researchers from Oxford in Great Britain as well as Adelaide in Australia. And the intent was breast cancer patients could benefit from a controversial hormone that most oncologists completely do not understand and completely disagree with. So the impetus of this article is from a couple patients that have recently said, well, my oncologist said, and as you well know, when I say to the patient, when you come back and say to me your doctor says, then let's do what your doctor says. When you come back and say, but my doctor says you're going to harm me, my doctor says this, my doctor says that, I politely say, well, I disagree with your doctor. Well, it used to be that the oncologist trumped us. Well, no longer will I sit by and say, well, just because the oncologist is a specialist, that what they say trumps us. So now I stand up and say, no, your oncologist is entirely wrong. Your oncologist does not know. Well, he's the expert. No, he's not the expert. He's clueless. Let me show you why. And let me give you these articles and see if you understand them better than your oncologist understands them, because they won't typically understand it. Only because that's the way that we're taught. And it's really a shame that that's the way we're taught. But that's the impetus for this article. As I go through it, you'll see. Progesterone may have an important role to play in the safe and effective management of recurring breast cancer. An international team of researchers involving the University of Adelaide is tackling the controversy over what some scientists consider to be a harmful hormone. They just don't get it. Arguing that it could be a game changer in the fight against recurring breast cancers that are resistant to standard treatments. The controversy centers on the different effects of the naturally occurring sex steroid hormone progesterone compared to synthetic forms, i.e. progestins like Provera, designed to mimic its actions, but don't in most tissues. Some, but not all, progestins have been linked with an increased breast cancer risk when used in menopausal hormone therapy, and that's what everyone misinterprets. Absolutely, I don't think there's one study that does not show that Provera increases the risk of cancer. It is minimal, but it does increase the risk, and why take that risk? As a result, the world fears using estrogen, but it's really not the estrogen because every study shows it's not the estrogen, it's the progestin, it's the Provera. There's an increase in breast cancer risk when used with menopausal hormone therapy, leading to concerns in the scientific community about the use of these drugs. Well, of course, every woman is afraid, they're scared to death of hormones. This television journalist says, every doctor that she speaks with says, no, get off the hormones. They're harmful. Don't take them. And it's like, you got to be kidding me. They don't understand it. But the journalist says, but I don't understand why they don't understand, because they're not taught or trained. However, in a paper now published in the prestigious journal Nature Reviews Cancer, an international team highlights that progesterone, when used in menopausal hormone therapy, does not increase breast cancer risk. It never has, it never will. I've been preaching the articles from the last 20 years that show that, but somehow everyone ignores the articles from the last 20 years that show benefit and protection. Progesterone may have an important role to play in the safe and effective management of recurring breast cancer. It also should have an important role in the safe and effective prevention of breast cancer in the first place. If it treats it, then maybe we should also be using it to prevent it. Instead of tamoxifen, this results in significant harm of estrogen deprivation when we can be using something much simpler and works probably just as well, if not better. Unfortunately, drug resistance of estrogen blockers is common, usually leading to recurrence. That's the problem with using tamoxifen. Moreover, current hormone treatments that target the estrogen receptor in breast cancer, especially specific inhibitors that block estrogen production, like aromatase inhibitors, can markedly impact the quality of life. That's why women stop using them. They can't stand the side effects, often leading women to stop taking the drugs or change their treatment. I've interviewed many of these patients, and I said, I'm your friend. Tell me, be truthful. Do you or do not take these drugs? And they all say, confide in me, say, no, I can't stand it. I can't stand the side effects. I tell everyone I'm taking it, but I don't. I can't. Well, that doesn't do any good if you don't take them, but they can't stand it. Professor Tilley says the team's recent studies, including a landmark research already published in Nature, suggest that a safe way of improving treatment without having a deleterious effect on quality of life does exist through the use of natural progesterone. What a concept. We see great potential benefits in adding progesterone to existing drugs that target the estrogen receptor, thereby helping to switch off the growth of cancer cells. The estrogen blocker, tamoxifen, blocks the estrogen receptor site, but it does nothing to stimulate the progesterone receptor, which has been shown to produce the proteins that are the breast cancer-resistant proteins. Tamoxifen has nothing to do with that. This gives us a unique opportunity to develop new hormonal treatment, which, when used in conjunction with the current standard of care, would improve outcomes for breast cancer patients. I'm not suggesting not using these drugs. That will really provoke ire in any oncologist. Their point, and my point is, well, then use it in addition to the drugs. When they take the drugs, they have terrible side effects that are just intolerable. Hot flashes, night sweats, temperature dysregulation, insomnia, they're absolutely miserable. Whereas taking progesterone helps to eliminate the hot flashes, night sweats, sleep issues, insomnia that you get when you take the estrogen blockers. Therefore, in addition to the standard care, would improve outcomes for breast cancer patients. What a concept. Unfortunately, there's been some serious misconceptions about the role of progesterone in cancer biology that so far have prevented it from being widely used in the management of breast cancer. We hope to change that thinking, Professor Tilley says. The team, which is highly regarded for its research into breast cancer, Dr. Tilley has written many articles in the past 15 years on breast cancer, believes this new paper will have global impact on clinical, scientific, and public opinion on the relative risk and benefits of using progesterone to treat women with breast cancer. I've told my television journalists, please take this article, give it to the doctors, and see what they say, and see if they can grasp it or understand it. Ultimately, we hope this work will eventually result in saving women's lives, Julie says. But the television journalist cannot figure out why all of her experts, all of her doctors don't know or understand this. That's what bothers her. She can't grasp it. That's not the way we're taught or trained, which is unfortunate. The medical literature on the use of progesterone and postmenopausal hormone therapy is often confusing and contradictory, with some physicians implicating natural progesterone with an increase in the risk of breast cancer. This is from a different article. It's a review of the literature on progesterone. The chemical structure of progesterone is quite different from chemically altered synthetic progestins like Provera or norethindrone, which results in different actions at the cell level. In this study here, meta-analysis of 3 studies involving 86,000 postmenopausal women reported that the use of natural progesterone was associated with a significantly lower risk of breast cancer compared with the synthetic progestins. In premenopausal women, anovulation and low levels of progesterone, because they don't make progesterone if they have PCOS, have been associated with a significant higher risk of breast cancer in postmenopausal women. The use of progesterone has been linked to lower rates of uterine and colon cancers, and may also be useful in treating other cancers such as ovarian cancer. In part 2, we looked at the most recent research on the use of progesterone in both protecting as well as treating ovarian cancer, in addition to breast cancer. Progesterone may be also helpful in preventing the cardiovascular complications of cardiovascular disease and preventing the neurodegenerative conditions such as stroke and traumatic brain injury. Progesterone is synergistic with estrogen in decreasing foam cell formation and plaque deposition. Provera, on the other hand, negates all of estrogen's beneficial effects. Yet we still see the medical academies promoting medroxyprogesterone, acetate, and Provera, and not progesterone. They say progesterone could be an alternative, but they completely ignore all these studies and data. It's really a shame that they ignore all this data. Conclusions. Physicians should have no hesitation prescribing natural progesterone, as the evidence is clear that progesterone does not cause breast cancer. Indeed, progesterone is protective and preventive of breast cancer. All women should be on progesterone unless they're making enough of it, which is a normal premenopausal menstruating woman. If they don't menstruate normally, they have PCOS, they are anovulatory, they need progesterone. Any woman that is postmenopausal needs progesterone also. It's very sad that I teach for a couple of other groups that say that, well, if you don't have a uterus, you don't necessarily have to take progesterone. And my contention is, and the reason you don't want to protect against breast cancer is, well, they say because they don't have a uterus. I said, you didn't answer my question. My question was, why is it that you don't want to protect against breast cancer? They always come back with, but they don't have a uterus, and I keep saying whether you would have a uterus or not does not factor into whether you should protect against breast cancer. Progesterone is sometimes implicated as a cause of breast cancer, but that's medroxyprogesterone acetate, which is Provera, which is a progestin. It is not progesterone. Unfortunately, most of the researchers and even the academicians that write the articles, like the one for the WHI, use the term progesterone. It's so completely wrong. These contradictory results are the result of researchers confusing the effects of synthetic progestins with those of natural progesterone, but they still call it progesterone because they just don't get it. The term it should be used is progestin, not progesterone. Progesterone is sometimes implicated as a cause for breast cancer. These contradictory results are the result of researchers confusing the effects of synthetic progestins with those of natural progesterone. It is not. They are not the same, but they just don't get it. Most of the doctors at my hospital, I've tried to train. They understand it. But doctors from other facilities, they just don't understand it. The difference in chemical structure is profound, and the results of different actions at the cell level are also profound. The only site in which Provera and progesterone have the same identical effect are on the uterus. Otherwise, their effects on all other tissues, organs, and systems are completely divergent. The evidence strongly suggests that natural progesterone is protective and preventive in breast cancer. I don't know how to get the message out to the oncology world. Dr. Tilley is trying to do that, but unfortunately, because of the conformational bias of what they've held on to in their brain for years, what they learned first, they can't get rid of, and they can't get it out of the brain, that progesterone does not cause cancer, and that progesterone protects against cancer. It's really a shame. Moving along, progesterone or progestin as menopausal ovarian hormone therapy. Recent findings, Provera increases breast cancer acting through the glucocorticoid receptor. We know that. That's been well shown through a multitude of different studies. Progestins in hormone therapy also increase thrombosis much more than estrogen alone. Progesterone has not been shown to increase thrombosis in any study anywhere in the world. Provera, but not oral micronized progesterone, increase monocyte cell endothelium adhesion. It increases platelet adhesion. It increases foam cell formation. It's bad to the blood vessel wall. Progesterone is not. Provera and estradiol have negative brain effects, whereas progesterone and estradiol have neuroregenerative brain effects. Which one would you like to be on? And it's thoroughly amazing that this data exists in our literature. It's in the neurology literature, but we just fail to understand it, fail to appreciate it, and when we read it, we ignore it. And I don't get it. Why do they do the studies? So that we can learn from them. Then why don't we pay any attention to them? Because we have a conformational bias, which is very unfortunate and difficult to get rid of and difficult to get out of our brains. P4, progesterone decreases breast cell proliferation and improves prognosis through a progesterone receptor alteration of estrogen receptor alpha. The beta receptor, not bad. The alpha receptor with estrogen is bad in both men as well as in women. However, when we give estradiol to men and women, we also stimulate the beta receptor, which overcomes the adverse effect on the alpha receptor. Micronized progesterone with conjugated Premarin or estradiol does not increase breast cancer in two prospective cohorts. Every study when we give micronized progesterone, we have not seen an increase in breast cancer with progesterone, only with Provera. Endometrial cancer is increased in menopausal hormone therapy with Premarin or estradiol and cyclic micronized progesterone. Don't cycle. Yes, that is correct. Endometrial risk is increased, the endometrial cancer. If you cycle it, don't cycle it, take it continuously. We'll look at what the recommendation was from the consensus of experts that convened last year in Europe as far as dose and regimen of progesterone to use. Progesterone does protect against breast cancer. Progesterone can increase endometrial cancer if not taken continuously because there's not enough opposition to estrogen stimulation. Micronized progesterone effectively treats vasomotor symptoms and deep sleep disturbances and can safely be used alone for symptomatic menopause and in patients with breast cancer. For those that can't take estrogen, micronized progesterone helps with vasomotor symptoms and sleep. For those that can't, for whatever reason cannot tolerate estrogen, or because they have breast cancer, progesterone is a safe and effective treatment to both help prevent the recurrence of cancer as well as for the vasomotor symptoms and sleep disturbances. We doctors give patients tamoxifen, then we tell them to just tough it out, just hang in there. Well, if you're going to give tamoxifen, my opinion would be that you add progesterone into the same capsule. And tamoxifen should never be given without progesterone. Tamoxifen causes terrible side effects that can be completely eliminated with the addition of progesterone. New experimental data in menopausal women taking Premarin and Provera provide explanations for the randomized controlled trial documented increase in cardiovascular disease and breast cancer. ACOG and NAMs, will just take a smaller dose. You'll get a smaller heart attack, and you'll get a smaller breast cancer. Oh, well, that sounds good. It makes no sense to use these drugs based on all the literature and data that we have, but yet they still are used. Progesterone decreases breast cancer progression by progesterone receptor modification of the estrogen receptor alpha, leading to decreased breast cell proliferation. Every study shows decreased epithelial stimulation, decrease in breast markers, protection against breast cancer, and it makes no sense that the whole world does not utilize progesterone for breast cancer protection. Progesterone also appears to provide additive effects with tamoxifen. Well, maybe the oncologist will buy that. Well, stay on the tamoxifen, that's fine. Maybe that'll make them happy. We're blocking the estrogen receptor site, and progesterone helps to eliminate a lot of the hot flashes and night sweats. So I've shown you several articles now showing the protection of progesterone, the decrease in breast stimulation, the decrease in breast cancer, and the improvement in menopausal symptoms that can be provided by progesterone, which is commonly ignored by most physicians, which is really a shame. There is now a twice documented observational cohort of data of breast cancer prevention when women are treated with estrogen and micronized progesterone in postmenopausal women. Micronized progesterone at a dose of 300 milligrams taken at bedtime. I take it a couple hours before bedtime. I don't take it, but I recommend that someone takes it. Significantly decreases severe hot flashes and night sweats. Improves sleep, protects the endometrium, has no negative cardiovascular effects, as does Provera. No increased risk of DVTs or PEs in comparison with Provera. Suggesting that alone, it is a safe and effective way to treat symptomatic menopausal women who can't or won't take estrogen. Then why isn't everyone utilizing it? It makes no sense. Why do they ignore these studies? Because they just don't understand, they just don't get it. Climacteric 2016, this is the International Expert Panel's recommendations on menopausal hormone and micronized progesterone. The recommendation is oral micronized progesterone should be taken at a dose of 200 milligrams per day, every day, continuously, not cycled. One of the other concerns was taking it in a cyclical form can increase the risk, as I showed you, of endometrial cancer if you don't take it daily. It makes no sense not to take it daily. The recent ELITE study gave it for 12 days. I don't know why they did that. I have no idea why they don't read the medical literature, and I do not understand why they do not understand progesterone. I can't believe they designed a study where it's only given cyclical for 12 days. It makes no sense when all the literature shows it should be taken daily at a relatively good dose. Lastly, they also showed that there's a multitude of studies where transdermal micronized progesterone cream does not provide adequate endometrial protection. If taking 200 milligrams per day in a cyclical fashion does not protect against endometrial cancer, neither will micronized progesterone in a cream form, which has never been shown to protect against endometrial proliferation or cancer in any study. I cannot emphasize that. That's one of my big pet peeves. If you're going to use a transdermal, use a submucosal, which means sublingual. Don't use a transdermal cream. You can't get good levels with it in the serum. You can get great levels in the serum with a sublingual progesterone tablet. Another study looking at breast cancer, this is from Breast Cancer Research and Treatment. The effects of estradiol and progesterone versus the effect of medroxyprogesterone on breast cancer markers. Compared with placebo, estrogen and Provera resulted in significant breast cancer proliferation and increase in breast markers, while estradiol and progesterone did not. These findings suggest that oral micronized progesterone has a much more favorable effect on the risk of breast stimulation and breast markers for postmenopausal women than does Provera. Climacteric. Progesterone derivatives selectively activate the P27 gene. They also activate the P53 gene. Both of these genes produce proteins that are breast cancer resistant proteins. The BRCA gene, when it's defective, does not produce the breast cancer resistant protein that the gene normally produces. That's why when you have a BRCA gene defect, you're at risk for cancer, because the protein that normally locks onto the mRNA and prevents it from becoming cancerous is no longer there, which puts women at risk for ovarian as well as breast cancer. Progesterone works by different mechanisms. One of the mechanisms is by downregulating the estradiol alpha receptor site. It stimulates also progesterone receptor sites to produce these proteins that could be promising drugs against breast cancer progression. It's one of the mechanisms by which it works. Fertility and sterility, conclusion, exposure to progesterone for 14 days reduced the estradiol-induced proliferation of normal breast epithelial cells. I would not use it for 14 days. I would use it for 30 days. But that's what they did in this study. These are a couple of Becky's articles from Maturitas. Androgen receptors are located throughout the body, including breast tissue, where testosterone decreases tissue proliferation. When I was a resident, a long time ago, we used injectable testosterone to treat metastatic breast cancer with significant reduction in metastases and reduction in size of the tumors. To this day, I still treat my patients that have active breast cancer or are breast cancer survivors with relatively good doses of testosterone. That's what Dr. Glasser does also. Androgen receptors are found in breast tissue. Recent clinical data supports the role for testosterone in breast cancer prevention. Women with symptoms of hormone deficiency treated with pharmacologic doses of testosterone, alone or in combination with an anastrozole, the aromatase inhibitor, had reduced incidence of breast cancer. What Becky does is she uses subcutaneous implants or pellets along with an anastrozole and puts it in patients that are breast cancer survivors. And then she watches and observes what it does. And her studies show that it's very effective. In addition, testosterone combined with effectively treated symptoms of hormone deficiency, testosterone combined with anastrozole effectively treats the symptoms of hormone deficiency in breast cancer survivors, and it was not associated with any recurrent disease. So, of course, you can't use estrogen in someone that has a recent breast cancer. You should not use it for at least 5 years. The 5 years is because that's the length of time that tamoxifen is given. In part 2, we looked at the 60 studies showing that in women that are breast cancer survivors, after 5 years, estrogen not only did not increase recurrence rate, it decreased recurrence rate and decreased overall morbidity and mortality from heart disease, cerebral vascular disease, diabetes, and fractures. But you can't give it in the first 5 years after. But you can use testosterone, which helps treat and eliminate these symptoms of estrogen deficiency. There's evidence that androgens are breast protective, and that testosterone therapy treats many symptoms of hormone deficiency in both pre- and postmenopausal patients. For those that won't take estrogen, but have terrible symptoms, testosterone eliminates the majority of those symptoms. Conclusion: testosterone or testosterone and anastrozole reduce the incidence of breast cancer in pre- and postmenopausal women, and evidence supports that breast cancer is a preventable disease by maintaining a testosterone to estradiol ratio in favor of testosterone. I somewhat disagree with that because I cannot find any study that shows that giving estrogen to a postmenopausal woman that does not have breast cancer increases the risk or incidence of that cancer. High levels are associated with it. We've already been down that road. But there's no study to show that giving estrogen to one that does not have it increases the risk. There is no study, that's part 2, there is no study in breast cancer survivors at 5 years when we gave estrogen to women that there was an increased risk or incidence of recurrence, mortality, or morbidity from breast cancer or any other disease, because it protects against heart disease, strokes, Alzheimer's disease, etc. My point of contention is in a woman that's a breast cancer survivor, I would recommend estrogen at 5 years. On the other hand, no oncologist will agree to that. Becky completely disagrees with it. Most of my oncologists completely disagree with it also. And of course, the opinion of the oncologist, who's the expert in breast cancer, trumps your opinion. On the other hand, those are not experts in hormones. They're experts at cancer. We're the experts in hormones. And until you can show me a study where giving estrogen increases the risk or incidence, you should not say that. Until you can show me a study where there's an increased incidence or risk of recurrence with testosterone and progesterone, and there's not because all the studies show the opposite, then your confirmational bias does not trump my scientific data that proves and shows that it is safe. It is very, very, very much indicated. There are 60 studies showing that estrogen can be safely given to breast cancer survivors and improve their morbidity and mortality. When you do not want to improve their morbidity and mortality, you want them to die sooner and be miserable, then don't give them estrogen. And of course, the drug companies are now saying, well, we need to make it even worse by giving them 10 years of tamoxifen. But no one looks at what happens in those long-term survivors that are taking tamoxifen as far as the quality of life or risk of recurrence, and that's a study that needs to be done. We see that in men that are taking LH-RH agonist for prostate cancer, the majority of the studies show an increased risk of dying, heart disease, and all-cause mortality in those that take LH-RH agonist. There's a decrease in morbidity and mortality in those that do not. Yet everyone gets it, but the mortality is increased. It makes no sense. Yeah, but at least they didn't die of prostate cancer. Yeah, but we killed them, and the ones that we did not treat are still alive. Yeah, but they have prostate cancer. Yes, but they're alive. Same study needs to be done with estrogen in women that are breast cancer survivors. There's lots of studies that have been done, but we need to do the study that compares tamoxifen and estradiol and look to see who dies first and of what disease, and then decide who gets what and why. If both estrogen reduces breast cancer, tamoxifen reduces breast cancer, and tamoxifen will increase the risk of heart attack, strokes, Alzheimer's disease, osteoporosis, and fractures, but giving estrogen does not, and it improves quality of life, which one should we be giving? Yet, unfortunately, well, my oncologist says, well, then you do what your oncologist says. I can't convince you otherwise, but I completely disagree with your oncologist. Well, he completely disagrees with you. Well, I think you then not need to take estrogen. Goodbye, good luck, and how you feeling? Like crap. Yeah, I know. I'm sorry. What do I do? Go ask your doctor. Another study, experimental and clinical data support the inhibitory effects of testosterone on breast tissue and breast cancer. However, testosterone is aromatized to estradiol, which exerts the opposite effect. Testosterone is aromatized to estradiol, which exerts the opposite effect. Yes, testosterone can be aromatized to estradiol, but at what level? What level of testosterone causes aromatization into estradiol? Testosterone is very beneficial because it is apoptotic to breast cancer cells, but the concern is, yeah, but it increases estradiol levels. Well, we'll look at some lab tests and see what those lab tests show. I read this all the time, but I also read where, no, it doesn't necessarily increase it. But even in Becky's study, this is her study, she says that testosterone is aromatized into estradiol, which causes the opposite effect, and that's why she uses Arimidex in her patients that she gives testosterone to block the aromatization into estradiol, and then you don't have to worry about it. However, in another one of her studies, she showed the opposite. She took this patient here with breast cancer, and she put 180 milligrams of testosterone pellets in and around the tumor. By day 46, there was a 7-fold reduction in breast tumor volume. But she goes on to say therapeutic systemic levels of testosterone were achieved without any elevation of estradiol, whereas in the study just before that, she says testosterone can be aromatized into estradiol. In this study, she says, no, it does not. Well, you're going to be hard-pressed to find an oncologist that will not treat with an aromatase inhibitor for 5 years. So if you have breast cancer, sure, I agree, go ahead and take an aromatase inhibitor, but I disagree not to use testosterone because in all of her research and all these other studies, we got systemic levels of testosterone without any increase in estradiol, and it certainly diminished tumor size, and in many of her studies significantly reduced breast cancer recurrence. The epidemiologic studies show that out of 10,000 women, the average risk of recurrence in women is 350 per 10,000. In Becky's study, she was able to get that down to 50 per 10,000 by using testosterone and anastrozole. Last but not least, final study, androgens inhibit the stimulatory action of 17-beta estradiol on breast tissue. It is true that 17-beta estradiol and Premarin increased stimulation of breast tissue, but I disagree that they increase the risk and incidence of breast cancer, because in every study when we give beta estradiol or we give Premarin, there's not an increased risk of breast cancer. There's a decreased risk of breast cancer in every single solitary study in the last 50 years. But everyone ignores it because high levels are associated with. In this study here, testosterone and dihydrotestosterone, DHT, inhibited proliferation and increased apoptosis in the epithelium of cultured normal cells exposed to estradiol stimulation. The decrease in proliferation and the improvement of cell survival was an androgen receptor dependent response. These effects were associated with changes in the proportions of estrogen receptor alpha and androgen receptor positive epithelial cells. And that's exactly what we want to do. In normal human breast tissue that are exposed to estradiol, yes, there will be proliferation. But when you stimulate the androgen receptor, these effects are changed. The alpha receptor site is blocked, and the androgen receptor site is stimulated, which helps to decrease stimulation and result in apoptosis. So even though people theorize that testosterone will increase estradiol, oh, you can't take testosterone, it increases estradiol, when you look at the outcomes, it doesn't make any difference. The outcomes are always positive for decreasing tumor growth that results in significant apoptosis of the cells. I wanted to show you a slide looking at levels. This is a little confusing. Anyway, the total testosterone is not on the slide, but the free testosterone down here was 49. This is Quest Labs. The normal range for an old, sick woman is 0.6 to 3.8. Optimal range for a young adult is 6 to 8. So the level that we should shoot for using this test is around 6 to 8, which is what I shoot for in my patients. This patient had a free testosterone level of 49. Ooh, really high. The total testosterone was not published on this page, but the total testosterone probably would be around, my guess, around 800 or 900 if this person has a free testosterone of 49. A free testosterone of 49 when optimal is 6 to 8 is extremely high and would indicate that if testosterone is going to aromatize into estradiol, it really will. Well, this patient's not on an aromatase inhibitor. And look at the serum estradiol level, it's 19. Again, examples of very high levels of testosterone. 49, that's like 6 times the level that it should be. Results in no aromatization or increase in estradiol level. And this patient is not on an aromatase inhibitor. So I want to do some lab tests and show you what I shoot for and why. These are LabCorp values. Unfortunately, in the last couple of years, LabCorp has changed the reagents for both free testosterone as well as progesterone. And I want to go through that with you. In this test here from LabCorp, the test code is 140103. They use the old ranges, which is 0 to 4. The old range used to be 0 to 2. I begged them, negotiated with them, explained to them that the new reagent that they were using unfortunately, was not accurate, and that they really needed to raise the ranges up to around 8 based on all the lab tests that I had sent them. Well, they agreed to raise it to at least 4, so the range for the new reagent for free testosterone with a direct measurement for code 140103, the range is 0 to 4. I shoot for the same level that I shoot for with Quest, which is 6 to 8. And most patients that have a total testosterone level of around 2 to 300, which is what we typically shoot for, that's what Becky shoots for, that's what the literature shoots for as far as symptomatic improvement. You will see a free testosterone then of around 6 to 8, but realize it's going to be markedly higher than the range that they have for old, sick people. Yes, a range of 0 is normal. Why you would want to have a level of 0, I don't know, but it's normal. But normal is not optimal, it's different. So I don't use this test code anymore, or this range, because the reagent that they're using, the new reagent, is all over the place and it doesn't make sense. But I want you to see what happens when you use this. Now, if you were to get the testosterone level up to around 2 to 300 instead of 143, that's about double this. Your free testosterone is typically going to go up to around 6 to 8 using this range, or using this reagent, or using this test code. You can use that one if you wish, and that's one possibility. On the other hand, the other code, which is the typical code that I use for women, is 081786. That's with LabCorp. But unfortunately, the ranges are confusing. They use a different reagent for this test too, and based on the manufacturer's recommendations, the range for free testosterone for here for old sick women is 0.1 to 0.8. That's the range of normal for old sick women. I don't use that range, and that's the range for the new reagent. However, with the old reagent, the levels that we used to shoot for were around 4 to 6. What I discovered was, with this new reagent for this test that have these ranges, putting your total testosterone of around 2 to 300 will result in a free testosterone of around 4 to 6, which is the level that we used to shoot for using the old reagent. So it just so happens that the new reagent provides levels that are very, very, very comparable and similar to the old reagent. What's confusing is that the ranges that they use over here for normal are completely divergent. So what I do, which is not evidence-based, but I'm showing you what I do, is I look at a total serum testosterone level of 2 to 300, which typically gives me a free testosterone, which to me is a much more accurate measurement, of around 4 to 6. And we'll look at those numbers. A recent article came out, published in the medical journal Menopause, and they looked at various doses and various ranges of testosterone total that resulted in improvement in symptomatology. And what they found was the highest dose of testosterone that they used resulted in a total testosterone level of around 2 to 300. The majority of the women that achieved levels of 2 to 300 saw symptomatic improvement without side effects, whereas the majority of the women that had levels from 100 to 200 did not experience improvement in symptoms, and those levels from 0 to 100 experienced nothing. So, if you look at achieving a level of 200 to 300, what Becky did in her studies was she shot for a level of 300 to 400 of total testosterone. Some women may get some side effects, acne, hirsutism with that high of a level. So what I shoot for using this test code is a total testosterone of around 2 to 300. I find most women will dramatically improve symptomatically at a total of that range and a free testosterone of around 4 to 6, not 0.1 to 0.8. If you want to keep your level 0.1 to 0.8, don't use the testosterone. Your level will be there. This person's on testosterone and the level's still 0.8, similar to this lab test. You will not see symptomatic improvement, and you will not result in any breast cancer protection. So let's look at some lab tests using this test code with a range that's printed on the lab slip of 0.1 to 0.8. This total testosterone is 200 with a free testosterone of around 3. That makes sense. Those are the numbers that you typically shoot for. If the patient feels well on that dose with those numbers, I will keep them at that dose and those numbers. The progesterone level down here is 21. Based on the recent consensus and based on past literature, you would like your level to be of at least 10 or greater for endometrial protection. There has been some issues with the progesterone reagent also. LabCorp is trying to correct that, and they're going to be using a new reagent, which hopefully will eliminate the problems that we've had with their new reagent, which reads low in comparison with the old. But hopefully that will occur in the future. But I want my progesterone level to be at least 10. This level of 21 is absolutely superb. Another patient, total testosterone of 443, a little bit on the high side. Are they symptomatically better? Yes. Any side effects? No. Most of you would probably lower that level of 443 down to around 200 to 300 because you're afraid of the number. This free testosterone of 8, I typically shoot for around 4 to 6. 8 is a little bit on the high side. If you don't like that number, then retest it. Wait 12 hours if you're using a transdermal cream. Wait 3 months if you're using a subcutaneous pellet, and then retest it. And those levels will be lower. And then when the level falls back down, you're not so upset with the number. You didn't change the dose. What you did was you changed how you measured it to get a number that didn't bother you so much. When I see this number, I do not change the dose. What I do is I ask the patient, how are you doing? I feel great. No, how are you doing? I feel fantastic. Okay, if you're feeling fantastic and you have no side effects on your skin, I'm not changing the dose. I don't want to see a different number. Yeah, but if somebody else sees that number, they're going to get upset. I explain to the patient, those are the numbers that we shoot for that are optimal for a young adult. If the number bothers you, retest it. Don't take it on the day of the test. The half-life is 24 hours. The level will fall back down. Retest it. You'll get a low level, and then everyone will be happy. As soon as the patient goes to their family doctor and says, these are my numbers, doc. What do you think? Oh, my God. You know, you're going to grow a penis. You're going to grow a beard with a level that high. What's he trying to do? Well, what he's trying to do is to provide symptomatic improvement and protect against breast cancer. That's what I'm trying to do. If you don't like the numbers, retest them. If you still don't like the dose, then lower the dose. It's quite fine. But I don't have an answer for, well, what if the patient then feels worse? I don't know. I don't have a solution for it. Don't test the number then. I showed this number here because it's a little scary. This total testosterone is 1,500 and a free testosterone of 15 in this patient who's always had perfectly normal optimal levels of around 200 to 300 total and a free testosterone around 4 to 6. Now I get these numbers. What's the possibility? The possibility was lab error, which it is in this case. The other possibility is they're using too much. You really got to put on a lot to get a level that high, or put in a big pellet. The other possibility is the husband's on testosterone that's being transferred by contact or touch. Well, that's a good thought, but the patient's husband was not on testosterone. So you repeat this, and when you repeat it, it comes back normal. If you see an abnormal lab test, don't jump. Just write another lab slip out and retest it. Chances are when you retest it, it will be normal. Why is it elevated? Why is the lab error? I do not understand. I don't know. I see it once a month. I'm just showing you those odd things that I see from time to time. If a patient truly had levels that high, they would be breaking out, hirsutism, complain of skin side effects, oily skin. They wouldn't feel very well. This person feels fantastic and there's no side effects. So I'm not going to change the dose. I'm going to retest it. And when I retested it, it was perfectly fine. Another patient who's a menopausal lady who is older and has severe osteoporosis, severe osteoarthritis, severe fibromyalgia, muscle pain, and deterioration. I titrated her up on the testosterone and let her do this herself. And when she finally found a dose that made her feel well, I tested her levels. Her total is 800, her free is 15. That's extremely high. If you're treating numbers, then lower the dose to get that number back down. Then the patient doesn't feel well. Well, now what do? I don't know. I don't have an answer for you. What I do is I call the patient and say, how are you doing? They're fine. No, really, how are you doing? I'm fantastic. Okay, well, I'm thinking about lowering your dose of testosterone. No, don't touch my testosterone. Okay, I won't. If they feel fine, maybe that is the dose that's required to make them feel well. If that number bothers you, reduce it. If the number bothers you, retest it and don't take it and get a lower number, and then that number won't bother you so much. The estradiol level is 115. That's perfect. I'm not going to change that. But this is what happens, and this is my strong criticism for ACOG and NAMs in the pharmaceutical industry. This lady is on a generic micronized prometrium. Generic meaning she gets it from her local pharmacy. She wants insurance to pay for it, and she gets it. The problem with the local pharmacy and their generic commercial available progesterone is that it's not micronized well. It says it's micronized, but it's not micronized. It's pushed through a filter. It's not micronized. And as a result, if it's not micronized, you will not get good levels. And this is a typical level that we see, 2.6 with a commercial available micronized progesterone. There's recent comments from AACE. There's recent comments from ACOG and NAMs. Only use commercial products of bioidentical hormones. Yeah, and when you do, this is the level you get. Well, that sucks. Yeah, I know. Is that going to put somebody at risk for endometrial cancer? Yes. They're criticizing my use of compounded hormones, and the levels of progesterone I get are 10 to 20 or greater, and I get a level of 2.6, and they say use commercial products. Disgusting. Absolutely, thoroughly disgusting. Again, the bias from the drug industry that speaks to us through our medical societies is inappropriate. Well, then you got to raise the dose, 400, 600, 800, in order to get serum levels up, but guess what? Insurance won't pay for it. So now the patient has to pay for it. Well, why didn't you just use a good compounded formula in the first place and not have to worry about upping it to 200, from 400 to 600 to 800 to 1,000 to try to get the levels up that insurance won't pay for? That's very expensive. When you could have achieved a very adequate level in the first place by using a good compounded bioidentical progesterone, either sublingual or oral. This patient has a total testosterone of 347, slightly high, a free testosterone around 5 to 6. That's where I'd like it to be, 4 to 6. I'm happy with that. The patient feels great on it. I'm not going to change the dose based on a number. A lot of physicians send me these numbers and they go, I'm uncomfortable with this number. I'm going to lower the dose. Well, you're not uncomfortable with the patient feeling well, are you? Well, no. Are you uncomfortable with the fact that the patient has no side effects? Well, no. I'm uncomfortable with the number. Perfect. Test it again. Don't take it. Then get the number, and that number will please you and you won't feel so bad. Did you change the dose? No, you just manipulated the time in which you tested it. When does the literature say that we should test these numbers? They don't say. They just say you should test them. Yeah, but don't they tell us when? Don't we need to know when? No, they don't tell you when. So you can test them anytime. Yes. If you want it to be high, test it right after you take it. If you want it to be low, wait 2 days and test it in 2 days. You'll get a number that's back down to baseline, because the half-life is around 24 hours. Again, I don't get upset with the numbers. I'm quite pleased with those numbers. Those are the numbers that Becky uses in her studies to make sure that the patients have breast cancer resolution. I'm using these numbers to make sure that the patient has breast cancer protection, assuming they don't have any adverse effects on their skin. As I've recently shown you in the courses, if a patient has this level and they have side effects on their skin, the first thing I do is not lower the dose. The first thing I do is I look at the body weight, I look at insulin levels. If they're premenopausal, I look at whether they have an FSH-LH flip to see if they have PCOS, because chances are, if you have a level this high and they have side effects, it may be due to low sex hormone binding globulin due to the fact that they've got PCOS or insulin resistance. That needs to be treated with metformin. You can treat with spironolactone, of course, if they have side effects. But most women I find that are menopausal over age 60 tolerate this level quite fine, and they don't have any changes in their skin, and they feel actually quite well. Progesterone level 9.4, that's close to 10, that's fine. No changes are needed there. Total testosterone 189, okay, not bad. Free testosterone is 4.6, optimal is 4 to 6. That's absolutely perfect. How do they feel? They feel great. Any side effects in their skin? No. I'm going to stay on that dose, which is perfect. Free T3 3.6, I want it to be 4.4. They need to go up on the thyroid. DHA is 429, a little bit on the high side. If this patient has some side effects of acne, I would reduce the DHEA first and not the testosterone dose. Why is the DHEA so high? Because they're on a double dose DHEA. Why are they on a double dose DHEA? Because as older women always have arthritis, and DHEA helps that. Estradiol levels 87, absolutely perfect. I'm happy with that. Progesterone level 1.7 on a commercial available micronized progesterone capsule, worthless. You'll also see these numbers with the new reagent that LabCorp uses. But on this patient here, I know that they were on a commercial available progesterone. I will take them off of that, tell them they got to pay for it. Yeah, but insurance covers my other one. Yes, but you're putting yourself at risk for breast cancer, endometrial cancer, if you do not optimize your progesterone levels. Total testosterone 373, a little bit on the high side. That's okay. Free testosterone is 8. Optimal is 4 to 6. With Quest, it's 6 to 8. Any side effects? No. I'm happy with that. There are side effects? Then reduce the dose. I'm happy with that dose. I don't see side effects in most patients. Estradiol levels 111. Perfect. Vitamin D is 9. Well, this person's obviously not on vitamin D. They will be on vitamin D quickly. Progesterone levels 4.9, a little bit on the low side. This is using the new reagent. With the new reagent, what we've done is we've multiplied it by a factor of 3.5. When you multiply 3.5 times 5, it works out to be 15. This level is good using the new reagent, but there's going to be a newer reagent above and beyond that hopefully will eliminate this problem that we have with the older, most recent reagent that shows that the levels are low because the reagent is not what we've used for the last 50 years because that's no longer being manufactured. Total testosterone 455, a little bit on the high side. But this lady here, again, is older, has bad arthritis, bad osteoporosis. I'm going to keep her number exactly where it is. If she has side effects, then yes, you can reduce it. Most older women do not. But again, if they have side effects, look at the fact that they may have low sex hormone binding globulin. You raise it with metformin. You raise it with thyroid. Her thyroid is optimal. You can also raise it by giving oral estradiol, which is my choice, because the oral estradiol raises sex hormone binding globulin, which will help lower the free. Progesterone levels 13, that's optimal, that's absolutely perfect. I will keep the dose there. Total testosterone 221, but the free is 168, not high enough. I want the level to be 4 to 6. I'm going to double the dose of the testosterone and try to get this level up around 4 to 6. When I do that, her total testosterone may go to 400. Yeah, but that's all protein bound. It's not the active form. Total testosterone is protein bound, does not cause any symptoms. It's the free that's the important one. And right now her free is low. Estradiol level's good, 79. Progesterone level's good at 20. No changes are needed there. This is one of my poster kids, who's now, I think, in her late 70s. She is a professional dancer. She's been dancing for all of her life and still continues to dance even into her late 70s. She can bend over, squat, do the splits, jump back up, and you will go, oh my God. But she doesn't feel well and she deteriorates. She feels absolutely fantastic, as she tells me, the best that she's ever felt in her life. Total testosterone is 588 with a free of 11. Any side effects on her skin? No. Her bone density continues to go up every year. Her DHA is 1,000 because she takes 50 milligrams twice a day for arthritis that she has now at age 78. Estradiol levels 90, perfect. for cardiovascular protection. Vitamin D level is 99, perfect for all sorts of protection. Progesterone level is 29, great for breast cancer protection, uterine cancer protection, etc. I'm quite happy with these numbers. Some of those may bother you, but that's okay. I'm just showing you what I do. Another patient who's a premenopausal patient, testosterone level is 222. I want the level to be between 200 to 300, perfect. Her free testosterone is 4. I want the level to be between 4 and 6, which is optimal for a young adult using the old ranges from yesteryear. Her LH is 13, her FSH is 6. She's got a flip. She's got early PCOS, but she's not having any side effects at all in her skin, and she feels absolutely fantastic. She's premenopausal. Postmenopausal lady, total is 208. Her free is 4.6. That's absolutely perfect. I'm happy with that. She feels great. Any side effects? No. DHA is optimal. Estradiol is optimal. Vitamin D is very low. Progesterone is optimal. That's perfect. No adjustments are needed, other than in the vitamin D. Total testosterone 368, perfect. Free testosterone is the more important one. It's 4. 4 is excellent. DHA is 300, excellent. Estradiol 131, excellent. Vitamin D is 60, excellent. Progesterone level is 7, not excellent. I would go to 300 milligrams on a progesterone to try to get that level greater than 10. Finally, coming down the home stretch, this lady is menopausal, thin, osteoporotic. We have her testosterone at 700. She feels tremendously better at that dose. I let her titrate up by herself to find the dose that made her feel well. When she found the dose that made her feel well without any side effects, her free testosterone was now 11. I let her stay on that dose because that's what she titrated to. Is that breast cancer protective? Absolutely. Her estradiol level 70, that's optimal for menopause. Progesterone level is 11. I want it to be 10. That's perfect. Her vitamin D level is 248. Uh-oh. What do we do here? Well, any level greater than 100 we know is abnormal. Levels greater than 100 can be toxic. And as a result, we want to keep the level less than 100 because if your level goes above 100, it can increase calcium and cause hypercalcemia. So with a level of 248, this lady probably has some element of hypercalcemia. Calcium level's 9. No, she does not have hypercalcemia. So then what do you do? Well, this lady's on a very high dose of vitamin D because she has a neuropathy. And she feels much better on that dose of vitamin D, and she doesn't have any toxic side effects from it. I don't suggest that you go this high, but the literature shows that levels greater than 400 appear to be associated with toxic symptoms. In the studies, levels less than 300, the toxic symptoms of hypercalcemia tend to resolve. That doesn't mean that you're not going to get that, but this is a lady who feels much better symptomatic-wise on a higher dose of vitamin D, which I've used to try to treat the neuropathy. She tolerates it well. She feels great on that dose, and as you can see, her calcium level is perfectly normal at 9.5. In fact, it's right smack dab in the middle of the range. So I monitor symptoms, no symptoms. She feels much better. I monitor her calcium scores. Her calcium score is always fine. I let her continue to take the dose as long as she doesn't have any side effects. I use the number as a guide to therapy to see if they have side effects. Your family doctor, when they see that level, are going to have fits. I tell her, don't let your family doctor see the vitamin D or test it. She says, you are my only doctor, and I'm not going to show it to anyone else, and she feels great. Okay, so there's lots of things that we covered today. Observation does not prove causation in regards to estradiol levels in men and women. Raising levels in men and women provide benefit and no harm. Don't extrapolate high levels being associated with harm to be what happens when we treat. It's completely different. We've looked at all the different recent articles on breast cancer protection with both progesterone as well as testosterone. I've looked at levels to achieve. I've shown you some levels, what I do in my practice, the levels that I achieve, what I shoot for. And of course, as many of you probably know, we don't advertise our practice. We don't advertise because all of our practice is word of mouth by providing good service, but also helping patients feel and function better. We use numbers as a guide to our therapy, but that may bother you. If the numbers bother you, don't test them. If the numbers bother you, retest it. Just lower the dose. It's fine. But this is what I do in my practice. And I've had great results and great success. Looking at numbers, just because the number is above the range of normal does not mean that it's not going to benefit them or cause harm. But the ranges that we see for normal are ranges that the lab uses that they've looked epidemiologically for old, sick people, and that's normal. There's nowhere that says you can't go above normal, and I've shown you in part 1, going superphysiologic with so many hormones, thyroid, testosterone, provide overwhelming benefits and symptom improvement, even though the level reads high. Okay, I hope you enjoyed the lecture. I will now go to questions and answers.
Neil, can I interrupt for just a minute?
You can.
For those of you that just joined us, please note in the lower right-hand corner of your screen, you should see the question and answer box where you can enter your questions to Neil. Back to you now.
Thank you, Mary. Do you see questions, Mary?
Not seeing any questions.
Okay. Well, if there's no questions?
You know what? Hold on, because I know there's questions coming in and we can't see them. I'm just wondering if people out there have questions, can put it in the chat box if they see that off to the right. And we're working on why we can't see the question, so let's just give it a minute.
While you have a minute, Dana.
Yeah.
I also want to introduce also to listeners, we're going to have a monthly webinar similar to the one that I've just done. But I'm also going to hold a monthly blog, which will be interesting cases. I'm going to enter various cases, situations, circumstances, or questions that people have sent me over the years and let you think about those questions, the cases, the circumstances, and how you would treat them or how you would answer the questions. And then I will then go back in and answer them. It will not be an interactive blog. It will be a non-interactive where you can access it anytime you want to, but you can read it on your own at any time and be able to look at all sorts of interesting cases and problems that I've collected over the last 20 years that I've been saving for these moments. And so I'll probably have about an hour's worth of reading in each one of the blogs of fun, interesting cases. I see a question.
You can also. Okay, good. Go ahead.
Hi, Steve. Steve says, hope all is well. It is. Recently in part 1, you recommended that when prescribing estrogen, a compounding pharmacy cannot compound meds if they're available commercially. Yes, that is true. Estradiol is commercially available at 0.5, 1, and 2 milligrams, but it's not commercially available at 1.5. So you can compound 1.5. You can't compound 1 or 2. But you can compound 1 or 2 if you combine it with estriol. So if you combine something else with it that's not commercially available, then you can compound it. But if it's something that's commercially available, then the pharmacist cannot compound it. You discussed it. It can be compounded as above with 0.1 milligram of estriol. Yes, it's true. You also stated that it can be compounded in doses other than the 1, 1.5, and 2. it can be compounded as 1.5. It cannot be compounded as 0.5, 1, or 2 because those are the doses that are available commercially from your commercial pharmacies. Yes, you can compound it in 0.9, 1.1, 1.6. You can compound it in 1.5 also because it's not available as 1.5, and 2.1. Yeah, you can compound it at any one that you want. So for example, I start with 1.5 oral estradiol, and then if the level's still subtherapeutic when I retest it, I go to 1.75. Then I can go to 2.0 or 2.1. Then I can go to 2.25, 2.5, 2.75, 3.0. So I can go up in 0.25 milligram increments by compounding it. You cannot do that because it's not available commercially in that form. Otherwise, you're getting out the razor blade and cutting the tablets in small pieces. Which of the two options would you recommend? I recommend just adding the 0.1 estriol onto the 1.5, 2.0 milligrams estradiol. That way it's easier for the pharmacy and sort of easier for you too. Amy asked, the progesterone can cause breast tenderness and discomfort. It can. Do you have a way of explaining that to the patient that's reassuring? Yes. Before a woman starts to breastfeed, progesterone is released and stimulates the epithelial or ductal cells of the breast to get ready to release milk. That results in a little bit of breast swelling and a little bit of breast discomfort. So that's what progesterone does, but it doesn't necessarily mean that stimulation, is causing harm. It's just a little bit of fluid retention. In every study, and you're asked, how can we reassure? In every study, progesterone protects against breast cancer. I'm going to bet, because this is what I see, I'm going to bet you that you're seeing the breast tenderness, discomfort, fluid retention, breast tension in those that are taking oral progesterone. Simply switch to the sublingual, and you should be able to avoid that because it's the oral first-pass effect of the metabolite that's causing the fluid retention. It tends to cause the breast discomfort. I don't see it. I haven't seen it in anyone that's taken the sublingual triturate or rapid dissolve tablet. Especially in light of breast cancer prevention. Well, you could explain that there's a little bit of fluid retention, and that's what causes the symptoms. But if you switch to the sublingual, you can avoid it. But, sure, women, when they get breast tenderness, will think, oh, my God, I'm going to get breast cancer. Oh, my God, it's affecting my breast. No, it is very protective against breast cancer. Use some of the articles that I showed you in this webinar to give to the patient to explain that it doesn't cause any problems. Paul Battle asked, progesterone receptor positive breast cancer also benefits from progesterone treatment? Well, I sort of wish you wouldn't have asked that question because it's going to take a couple minutes to explain it. So let me give you a case scenario. Premenopausal woman, 45 years of age, developed breast cancer. She's being treated with tamoxifen to block the estrogen receptor because she has an estrogen positive and a progesterone positive receptor tumor. She normally menstruates. If she normally menstruates for 2 weeks out of the month, she's producing progesterone. Well, if she's producing progesterone and she has a positive receptor site tumor for progesterone, then what do the oncologists use to block that receptor site? Nothing. In postmenopausal women that have progesterone receptor site positive tumors, what do you use? Nothing. Well, shouldn't we be using something to block that receptor site if it's positive? No. What makes you think that stimulating the progesterone receptor site causes the tumor to grow? Well, because that's what happens with estrogen. You stimulate the receptor site and it causes the tumor to grow. Well, maybe stimulating the progesterone receptor site causes the tumor to regress and become apoptotic. Aha. That's why we see all these studies with progesterone showing that both in vitro and in vivo, progesterone is apoptotic to cancer cells. If you ask the oncologist, sometimes they go, well, we don't know because we don't have a blocker. Well, if progesterone was so bad, you'd give some sort of pill. You could use casodexlupron. You could use an LHRH agonist. to block the production, the lower FSH-LH, so that you completely shut down your ovaries. Do we do that? No, we don't do that. Why? Because it's not necessary. It doesn't. We don't need to. In fact, stimulating that progesterone receptor actually is beneficial. Every tumor that has a progesterone receptor that's positive has a good prognosis. It's the progesterone receptor negative that doesn't have a really good prognosis. Almost all tumors are progesterone receptor positive. So, no, you don't need to block the receptor site. Yeah, you need to stimulate that receptor site, and you stimulate it by giving progesterone. I hope that that explains it. So just because it's positive receptor site on the progesterone doesn't mean that it's going to cause the tumor to grow. It can stimulate the cancer to become apoptotic, and that's why we want to stimulate that receptor site with progesterone. Ryan asked, will the webinar be uploaded to the WorldLink website to view later? Absolutely. Dana and Mary will take care of that. Janet says, will the webinar be uploaded? Yes, it will be, to view later. Debbie asked, if using Quest Labs for testosterone, what range are we shooting for testosterone? If you're looking at men, the upper end of the range for a young adult for a man is 210, 220. If you're looking at women, the upper end of the range is 6 to 8. There are some Quest Labs that actually use a different machine, and their optimal is 8 to 10, but most of those machines have sort of gone by the wayside. Now the range is 6 to 8. So that's the level that you shoot for the upper range for a young adult for Quest. And that lab test that I showed you where it says 46, well, yeah, that's high, but if you're wanting to stay within the range, that's fine, but there's no article that says that you must stay within a certain range. The range that I shoot for is where most people tend to find benefit. Or that's the range that we used to shoot for because that was the upper end of the range for a young adult using the old labs. But when as time goes on, they changed the reference ranges, even though the reagent stays the same, and that's what they've done. They've lowered the range, even though the reagent's the same, they've lowered the range, which is, again, confusing. That's why I use the ranges that they used to use. It's still the same machine, still the same reagent, but what's changed is the ranges have been lowered. Next question. The patient had a T3 level of 8.3. I think it was a free T3, 8.3. How about testosterone level achieved for an active breast cancer patient on tamoxifen? Are you talking T3 level of 8 meaning free testosterone, or are you talking T3 level meaning thyroid? I'm going to assume that since we discussed testosterone that you mean a free T3, meaning a free testosterone level of 8. What dose of testosterone, or what level of testosterone should be achieved for an active breast cancer patient? Well, I typically shoot for a level of around 300 total for both labs, and with LabCorp, a level of free testosterone of 6, and with Quest, a free testosterone level around 6 to 8. And if she's on tamoxifen, yes, that's fine. Yes?
Sorry, he just clarified it with me on a text message. It's the free T3. I think he saw up on a lab value.
Free T3 meaning thyroid? The reason I was confused, if it's free T3 at 8, the next sentence was about testosterone, so I assumed that it was free testosterone. The last patient that had a free T3 level of 8, okay, yeah, that's fine, that's optimal. What about the testosterone level achieved for an active breast cancer patient? The answer is the same that I just gave on both the free testosterone for Quest and for LabCorp. Phyllis asks, what's the recommendation regarding progesterone for patients who are on BHRT with large uterine fibroids, including patients that have had a fibroid necrosis, as progesterone has been reported to link to fibroid enlargement? Yeah, it has been linked to fibroid enlargement. It's extremely rare, and if you look at all the other data, it's linked to fibroid regression or shrinkage. So it's similar to breast tenderness. Most of the time, women on progesterone have a decrease in the breast tenderness because of the downregulation of receptor sites. A rare individual will have an increase in breast tenderness with progesterone. Most progesterone, fibroids stop bleeding, which is why if somebody has a fibroid, I double the dose of progesterone. If they're on 200, I go to 400. And most of the time you can prevent or stop the bleeding of a fibroid by doubling the dose of progesterone. A rare individual will have an increase. Well, if that's the case, it makes it worse, then ablate the fibroid, sent to the interventional radiologist for fibroid ablation. What's the range of progesterone that I'm shooting for to be optimal? A level of 10 or greater is optimal. If a patient had breast cancer, I would probably shoot for levels, 20 or 30 or greater, much higher. Janet says, when do you test blood levels in relation to the hormone administration? Depends on what hormone that you're talking about, but simply put, 5 hours. We review all of that in part 1, the different doses and different times in which we test them. Kim says, how do you know which ranges to go by if you use a different lab other than LabCorp or Quest, such as CPL? You have to contact CPL and ask them for the ranges for young adults. There's no chart that looks at all the different ranges for all the different labs. So, sorry, there's no conversion chart between all the different labs. Dr. Cruz says, please comment about a patient with HERS2 gene who has breast cancer, their cause, treatment, and post-chemotherapy. Well, if you're HERS positive, then you need to take Receptor. So if it's estrogen positive, it's an estrogen blocker for 5 years. If you're progesterone positive, I recommend progesterone for 5 years and then beyond. You don't need to do anything different if it's positive or negative progesterone. If it's Herceptin positive, then you need to take Herceptin for the length of time that you would normally treat, which I believe is 5 years. So that's how I would treat that. And after 5 years, if you're cancer-free, then you are deemed cured. Dr. Gordon says, how fast do you have the patient titrate up on testosterone? About every month or two. Lane, what was the explanation of when the free testosterone is over 15 when the level of total is around 300? Or to look at it generally with men and women, sometimes I am getting a 10% or much greater in the free with a normal sex hormone binding globulin. You can. There's other proteins that bind onto it, albumin and other, that can adversely affect binding and raise and lower the free testosterone. That's typically why I tend to look more at free than total. But sometimes the free can be confusing because the ranges that are printed on the lab slip are not the ranges that are typically that you should be looking for. Again, to go back over that again, the old ranges that we used to shoot for with LabCorp with the old reagent that's no longer available is a level around 4 to 6. And you usually would get a total testosterone around 2 to 300. Well, with the new reagent and the new ranges, the total testosterone is still around 2 to 300. But the lab value for the free is 0.1 to 0.8. Yes, but the levels that you get using that lab test are typically around 4 to 8, just like they used to be with the old reagent. So I use the same ranges that I used to use for the old reagent, which is around 4 to 6, even though the lab test slip says 0.1 to 0.8, which I feel is very inaccurate and should not be utilized. But I can't convince the people at LabCorp to change it or to alter it because that's the range that they got from the manufacturer. Can sexual activity or exercise within 2 days be affecting this in particular? Yeah, sure it can. Octavia says, can we get the literature citations from the evidence base that you use today? Yes. In fact, they should be at the end of this section, all the articles that I discussed. I think Dana has posted that on the site as to the articles that I reviewed. Adam says, please comment on progesterone receptor positive cancer. That's the one you want. Progesterone receptor is always a positive indicator, and I would use progesterone to treat progesterone receptor positive cancers because it stimulates the progesterone receptor to kill the cell or be apoptotic to that cell. Francis asks, can you comment on the use of urine and or salivary hormone assays via blood to monitor patients on topical hormone replacement therapies? You can get extremely high levels in the urine and saliva when you use a transdermal cream that you will not get in the serum. all the recommendations are not to use saliva if you're using transdermal, because the saliva levels can go extremely high and you can be very, 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 very low in the serum. But the feedback to that is, well, but the saliva measures the free. Well, how can it be measuring the free when the actual serum level is very, 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 very low? Well, it measures the free. Well, yeah, but the free in the serum is low. Well, that's because it hides. Well, if it hides, it's not free, is it? So anyway, we go over that in great detail in part 1, but also part 2, I do an hour-long lecture on saliva versus serum and looking at various lab tests. Ryan asked, you want a progesterone level greater than 10 with progesterone receptor tumor? I would like it probably, 30 or 40. I would double the dose. Steve Lasser, hi Steve, asked, didn't the Nurses' Health Study show some increased risk of breast cancer in patients who are currently being treated with HRT, even without the use of a progestin? Yes, it was a 1.3 over long term, but remember those are observational studies and not randomized controlled trials. The longest one to date, I think, is the Danish trial, or the Danish osteoporosis study, which was 10 years of the 5-year follow-up, and we don't see any breast cancer in the randomized trials, only in the observation. But remember, that was an observation study. It was estrogen alone, and even in the observation studies or the randomized trials with progesterone, the relative risk is always less than 1. I never give estrogen alone. It's always estrogen with progesterone. Joe asked, you use Quest. I can't get any women's progesterone level above 10. I think that they're starting to use the old reagent, I mean that new reagent also, because they ran out of their reagent too. Despite 200 or 300 milligrams of micronized progesterone. Have you seen any issues with Quest? Yes, we're starting to see recent issues with Quest. I don't use Quest, but recently practitioners have been sending me their very low levels, where in the past they were getting really good levels. I don't know what reagent the Quest is now using, because their machine is different than LabCorp. You'll have to contact them. But if in the past your levels were always great on the progesterone that you're using and you haven't switched progesterone and now the levels have fallen, then what you have to do is then come up with a factor. Like, if all your levels are now 5 and the past levels were 15 or 20, then you have to multiply by a factor of 3 to 4. I'm sorry, I can't, I don't know all the other, I don't have experience with all the other progesterones from all the other labs. Lane asked, what was the explanation of when the free testosterone is over 15, when the level of total is around 300? Well, if your sex hormone binding globulin level is low, then your free can be very high. Or to look at it generally with men and women, sometimes you're getting a 10% or much greater free with normal sex hormone binding globulin. Yeah, there's other factors, other binding proteins like albumin that can bind onto it. So it depends on what your other levels of other binding globulins and albumin, which binds it weakly. That's typically why I look at the free and not necessarily the total. I showed you a couple labs where the total was around 200 to 300, but the free was high. It went into the labs where the free was actually lower. So that's why you focus pretty much on the free and not the total. But the total sort of gets you in the ballpark, and then you can use the free to sort of see where you are. But again, everyone wants to make a big deal out of it. I treat the symptoms. I know you want to optimize. Then I optimize with the free testosterone around 4 to 6 with LabCorp, or 6 to 8 with Quest. Can sexual activity affect it? Yes, it can. Sure. How fast do I titrate up? Fast, every month or 2. How do you know the ranges of using different labs? I think I somehow flipped back up, and those are recurrent questions. Dr. German says, thanks, Neil. You're in Portugal. Oh, really? Oh, good. Well, have fun, Richard. I was just up your way in Monterey this past weekend teaching a course. Hi, Ursula. If you ever want to meet a sweetie pie, meet Ursula. Ursula, Dr. Thatch says, having tough time getting progesterone levels up. Hopefully that's the only thing you're having trouble getting up. And yeah, it is. It is an issue, and I think it's because of the new reagents that are being used. I don't have an answer with LabCorp. Typically with a new reagent, in some states, again, it's different from state to state. And if you're having trouble with it and the levels are considerably low, like around 3, 4, or 5, multiply by a factor of 3.5, and that will give you your true value. I don't have any other suggestions, I'm sorry, other than increasing the dose of the progesterone, which I think is fine. I mean, probably 25% of my patients are on 200 milligrams orally, 50% are probably on 300 milligrams orally, and probably another 25% are on 400 milligrams oral in order to get the levels to be adequate. Rick asked, any research that shows that testosterone causes increased H&H in women? Not that I've seen. I know that it does, H&H does go up in women that live at altitude, but not as much as in men. And again, that's a testosterone-generated increase in progenitor cells that causes the H&H to go up. Gina says, so what is the flip that you're talking about with PCOS? The flip is in the FSH-LH ratio. We review all of that and how to diagnose PCOS in part 2. If you have the ratio is normally 3 to 1. When you get a flip, then you've got PCOS. Hi, Ashok. The esteemed Professor Dr. Kadambi asked, you showed us some outliers where testosterone levels in some women were very high on testosterone replacement therapy. What would be a more typical case? A more typical case would be standard testosterone total is around 200 to 300. The free testosterone total is going to be around 4 to 6 with LabCorp and 6 to 8 with Quest. Those are the levels that I have most of my patients shoot for, and most of my patients have those achieved levels. If they're not, then I will bump up the dose, and I will go up on the dose whenever I check the levels every 2 months or so, and then increase it. And then once I get those levels that are optimal, then I stay on that dose. If the patient is still symptomatic and needs more, then I let the patient titrate up themselves by increasing their dose based on achieving whatever their goal is or whatever symptomatic improvement they're trying to accomplish. Trina writes, can DHA be used in cancer patients? Yes, it can be. Now, I assume you meant DHA EPA, and you did not mean DHEA. So DHA, which is a part of omega-3 fatty acids, can be used. What was the explanation of when the free testosterone is over 15, when the level of total is around 300? I think I did that one. Somehow or another I flipped back up. Can you say again when you need to multiply progesterone level by 3.5? With LabCorp, if you have a level using the new reagent that's around 2, 3, 4, or 5, and you repeat it and it's still low, you're using the new reagent, which does not measure metabolites. The old reagent measured progesterone and pregnenyl glucuronide metabolite. The new reagent does not. So in order to achieve a level of at least 10, you have to use a multiplier of 3.5 using the new reagent, which will typically give you, if your level is 3, multiplied by 3.5, a level greater than 10, which is therapeutic and safe. Bruce asked, what is the progesterone reagent issue that relates at Quest? Quest is now starting to use a new reagent also because they ran out of their old reagent. So you'll probably start seeing the new progesterone levels markedly abnormal unless you use, the test that we use was the old equilibrium assay. If you want to get a little bit better result, you can use the liquid chromatography mass spec, the LCMS. The problem with it is the cost is about 4 times as much. But if you're confused, use the LCMS test, liquid chromatography mass spec, and that will give you more accurate than the old equilibrium. But again, it's expensive. Tony asked, can you review the data on testosterone be preventive in breast cancer? Tony, go back and look at the webinar. There's about 10 articles on testosterone both treating as well as being preventive in preventing breast cancer. Debbie asked, what's the total and free levels for Quest? The total is 1,200 for men. The total that I use for women is around 300. And for the optimal range, are you targeting for the progesterone is 10? Yes, that's correct. Kent Holtorf asks, you're kidding, Kent, are you listening? Oh, what a compliment. We need to get together, Kent, and we need to talk. Anyway, Kent knows this probably better than most, who has written so many of the articles in the medical literature on bioidentical hormones. Kent, we all thank you for that effort in doing that. Do you monitor the ratio of progesterone to estrogen, or just try to keep the progesterone above 10? I don't look at ratios. I just try to keep the level above 10. Why 10? Because it's been shown in the literature where that's where the level should be for endometrial protection. And some studies show that the level being less than 10 will increase endometrial proliferation, which could potentially result in cancer. So the magical number of 10 comes from a multitude of different studies, and OBGYN expert panels recommending a level of at least 10 be necessary or achieved in order to assure that you do not have endometrial proliferation. As far as breast cancer is concerned, there's no number that's magic, but in the Part 2 studies, the study showed that the higher the level of progesterone, the more downregulation of receptor sites, the more decrease in breast markers, et cetera, et cetera. And the best was when you got a level of around 300, which is what you get at term pregnancy for maximum downregulation of breast markers. Well, it's really hard to get a level of 300 by taking supplemental progesterone. So 10 at minimum. If you have breast cancer, then I would use a level of 20 or greater, and probably a dose of at least 200 milligrams BID, and then monitor the levels and adjust it. Anyway, Ken, thanks for listening. Dr. Haydar says, my estrogen is high. What do you do besides taking DIM? I'm sorry, I don't have an answer for you. How do you know your estrogen is high? Well, you measured it. Why did you measure it? I don't measure estrogen. So I measure estradiol, and I prescribe estradiol. I don't measure estrone. If you're worried about estrone, the largest studies to date show that Premarin, which is 50% estrone, results in decrease in breast cancer risk. So if you're worried about estrone causing cancer, it doesn't when we give it. If you're worried about high estrone levels being associated with it, yes. High levels of estradiol and estrone are associated with it, but those are baseline levels that come from visceral fat. It's the visceral fat that increases the risk, not the estradiol. Because in every study, when we give estrone and we give estradiol, there's a decreased risk and prevention of breast cancer when we give it. I don't measure it. I don't chase the ghost. Dr. Martinez, does the route of administration alter a commercial? Yes, it does. Dr. Thatch asked, even after 300 milligrams PO-QHS, adding PO in the AM doses, now trying the sublingual, how much does it take? You will get a rare patient that requires a higher dose. Start with 100 milligrams sublingual trituret. Most of the time with the sublingual, I'll get levels of 15 to 20, just with 100 of the sublingual. So how much does it take? I don't know. Try it and see. Maybe they're rapid metabolizers. I don't know. It's an individual thing. Rarely do I have to have patients on 600 milligrams, but I probably have a dozen patients on 600 milligrams of progesterone in order to provide shrinkage of the endometrial stripe, elimination of the endometrial hyperplasia, and to get levels at least greater than 20. Denora says, very useful lab result examples. Thank you. Thank you for thanking. Ryan, you want the progesterone levels to be greater than 10 for progesterone receptor cancer. And I want the levels to be 20 or 30. The more that you stimulate the receptor, the more apoptotic the progesterone is to the breast cancer cell. Progesterone doesn't stimulate the cell to grow. There's no study showing that progesterone causes the cell to grow. Estradiol, yes. The cancer will grow if it's an estrogen-positive tumor. The tumor will not grow if it's a progesterone-positive tumor. It will shrink. It will go into an apoptotic phase because you're stimulating that progesterone receptor, which causes apoptosis, not growth. Lori says, just a comment, incredibly valuable webinar, great refresher. Thank you so very much. Hi, Pete. Pete says, hi. Hope all is well. It is. Regarding progesterone in LabCorp, do we shoot for greater than 10? Like with the old reagent, yes. Take the current level if you're using the current reagent until they get the new reagent in place, and that's only in a couple centers. Take the current level with LabCorp and multiply it by 3.5. And that will give you the number that correlates with our old goals of to be less or greater than 10. Does the route of administration of commercial progesterone after absorption, i.e. vaginal or rectal? I don't use vaginal or rectal, but yes. Studies show that the rectal absorption of the vaginal progesterone, even in very high doses, it's good, but you have to use a high dose BID. So yes, it is affected. But commercial is not bioidentical. Yeah, commercial is bioidentical, absolutely. It's just not micronized. The old prometrium was very well micronized. In fact, all the world studies are done on prometrium. But the new generic commercial available micronized progesterone, which is a generic for prometrium because prometrium is not available because it's too expensive, is not well micronized, and therefore you will not get really good levels with it, which is why I don't use commercial micronized progesterone. If a patient would insist on using commercial available progesterone, then I wouldn't even test their levels because the levels could be very, very poor. And then you have to increase the dose and then go through the hassle and then to get the insurance denial. I don't go there. If they have to use a commercial, if you are using commercial, then I don't test the progesterone levels because you're not going to be able to get good levels with the current, let me use the term, non-micronized, not truly micronized progesterone. When using testosterone for breast cancer patients, do you recommend testing for the estradiol level? Yeah, sure you can. I do that, and that's what I've been doing for 10 years. And I've never found estradiol levels to go up when I give testosterone. The oncologists think that it goes up. The literature says that it goes up. But in my experience, it does not go up. And there's also literature, part 1, under the estrogen section, that shows that giving testosterone to women does not increase estradiol levels. To prove it to you, the oncologist, and to the patient, measure levels before and measure levels afterwards, and you will not see the estradiol level change when you give testosterone. I know it changes on paper, but that does not mean that it changes in a lab test. What are your recommendations regarding progesterone for patients who are on BHRT with large uterine fibroids? I think I already did that one. You give progesterone. Any specific questions to ask patients other than how they feel? No. How do you feel and any side effects? Otherwise, no. What sublingual dose of progesterone corresponds to 200 milligrams oral, 100 milligrams? Do I recommend a certain ratio of a prescribed dose of progesterone estradiol? I do not. Maureen asked, you've had micronized progesterone taken the night before, so approximately 15 hours before the blood draw. Micronized progesterone half-life is around 12 to 16 hours. So if you take it the night before and you test the next day, you'll still get good levels. Your levels are often very low. They're low either because you're using a micronized progesterone that's generic, or using it because your levels are low because using LabCorp and the reagents are not correct. Even the progesterone 400 milligrams. Do you usually test the progesterone at 15 hours? No, I usually test it like at 11 to 12 hours. But you don't have to take it in the morning and then test it, because if you do, you'll get sleepy. No, I get really good levels. You take it at 11 o'clock at night, test it at 11 o'clock the next morning, your levels should be just fine. I've also had patients with extremely high levels like 85. Is it possible with progesterone that high to downregulate estradiol too much with levels being that high? No, not at all. I have a gal that didn't seem, memory-wise, memory-wise, skin-wise, to be getting the effects of estradiol. I'm not sure what that says. But if they're not, then up to estradiol. If you want to lower the progesterone level, yeah, that's fine. Just make sure your level's, very adequate. Don says, what dose of sublingual P4? 100 milligrams starting. And how frequently taken to achieve optimal levels of at least 10? I test it every month until you get there. Do you use the micronized progesterone at bedtime in addition to sublingual? No, I don't. I get very adequate levels with sublingual. Dr. Martinez asked, ideal range of estradiol for pre-post-menopausal female. I don't test estradiol levels in premenopausal women. You don't need to because you don't know where you are in the cycle. Maximum dose for postmenopausal women, typically around 75. Maureen asks, I have a patient that told me a story of taking bioidentical progesterone and had flushing, heart pounding by mouth progesterone with oral. Given that information, I started on sublingual progesterone thinking that the root may be the problem. She had a similar reaction, not tolerant of progesterone. Some women are not tolerant. Any suggestions? Yes, I would use a vaginal suppository. She has osteoporosis, so needs E2, yes. Progesterone also needs, but she can't tolerate it. We go over that a lot in the courses as to what the alternatives are. The alternative is to use a synthetic progestin, use a Mirena IUD, or use a transvaginal progesterone troche. Don asked, do you recommend premenopausal use progesterone QD as opposed to cycling? I do. Do you augment the doses, lower the dose the first 2 weeks, one dose? No, I don't. I keep the same dose all the time. Dr. Martin asks, can you use BHRT in patients with a DCIS, ER? Yes, I do. Janet asks, why do I not use bioavailable testosterone levels? You can, I don't. I use the free because bioavailable typically means that which is bound to albumin and other weakly bound proteins, which just makes it confusing. Marina asks, I have a patient with postmenopausal bleeding and kept going up in the micronized progesterone trying to get bleeding to stop. Patient was out of state and I recommended she go to another in-state provider who ordered uterine ultrasound to measure the endometrial stripe. Yes, that's good. The other provider stated started her on prometrium and she stopped bleeding within the week. Endometrial stripe was borderline high, so she probably just had some dysfunctional uterine bleeding. Any thoughts on why micronized high-dose progesterone wouldn't stop bleeding and the prometrium stopped bleeding within a couple days? No, I don't. Maybe that was her time to stop, but I don't have an answer to your question. Dr. Martinez asks, do you only use transdermal testosterone and at what dose in the aforementioned patients? It depends on age and it depends on weight. We go over that extensively in part one. There's an hour-long lecture on dosing of testosterone. Sorry, I can't do it here. It would take me an hour to go over all the adequate dosing. And there's various types. You can use transdermal, you can do pellet, and you can use an oral capsule. Dr. Thatch, does it matter the pathology type of the breast cancer in order to use the testosterone? No, I know there's like 4 different pathologies, and so far all pathologies seem to have responded and have become apoptotic to the use of testosterone. I think it has to do with the androgen receptor, and stimulating the androgen receptor seems to have an effect on all different 4 subtypes of cancer. Don asks, are there BHRT E2 ranges that have been proven to be safe for breast cancer? Yes, levels less than 30, which is a typical menopausal level. And Dr. Cruz, please comment about H2 gene post-chemotherapy treatment and the use of BHRT. If you're 5 years out and you have the Herceptin, and you've been on Herceptin for 5 years, yes, you can use BHRT. Okay, my goodness gracious, it's been 2 hours. I'm pooped. I hope that was informative. See you at the next webinar. Mary, Dana, Chris, thank you very much. Goodbye, everyone.
Thank you, Dr. Rosier. I hope our listeners enjoyed it as much as I did. Our next webinar will be in January 2018. On behalf of WorldLink Medical, we would like to wish you and your family the best in the upcoming holiday season, and thank you for your continued support this past year. Thank you again, Dr. Rosier, and everyone who joined us. Have a wonderful rest of your day.